Hello and welcome to another episode of our new oncology podcast series, Onc Now, with me, your host, Dr. Jonathan Sackier. This series was designed to spotlight the leading experts in all subspecialties of oncology, and today I'm delighted to be joined by Professor Janet Abrahm. Janet earned her medical degree from the University of California, San Francisco, UCSF, followed by an internship, residency, and fellowship in hematology and oncology at Massachusetts General Hospital and the University of Pennsylvania. She served as chief resident at UCSF's Moffitt Hospital and pursued additional training in pain assessment and quality management. Now, Janet is a professor of medicine at Harvard Medical School and an institute physician at Dana-Farber Cancer Institute, practicing palliative care at Brigham and Women's Hospital. Janet is a trailblazer in supportive and palliative oncology, and the good doctor founded the first palliative care service and fellowship at both the Dana-Farber Cancer Institute and Brigham and Women's Hospital. Outside of medicine, Dr. Abrahm is a lover of books and art museums, and hoping, in fact, to view the National Gallery's Van Gogh exhibit in January. So it's my pleasure to welcome Professor Janet Abrahm to the podcast. I hope you enjoy our conversation. So, Janet, welcome to the podcast.
Thank you very much. Very pleased to be here.
Fantastic. So I mentioned art in my introduction, Janet, and I'm a bit of a Luddite in many regards, and I'm a grunting surgeon, so I don't know that I'm terribly sophisticated, but I love looking at art through medical eyes. You know, did that figure have anemia, cachexia, heart failure? And I'd love to hear your perspectives on your favorite artists. And just a recommendation, if you've never been, the Burrell Museum in Glasgow is one of my favorite in the world. It's absolutely spectacular. So favorite artists and galleries or exhibits you'd recommend?
Well, I prefer non-figurative art, so I like the Impressionists. I find I can lose myself as though I'm taking my glasses off and I'm nearsighted. And I discovered Boston in the spring and the fall, and I'm originally from San Francisco, so we had no seasons. So I think the Impressionists really speak to me because of the way they capture the way light changes, which I find fascinating. I like our Boston gallery, the Museum of Fine Arts. They have a very wide, interesting selection. And recently, for example, they're very good visiting exhibits. So I saw a wonderful juxtaposition of selected Henry Moore and Georgia O'Keeffe using the maquettes and showing his workroom and how the maquettes were really where he created. And then he let his assistants make things bigger. I like galleries that are intelligent and help you see things differently than you would normally see them.
Yes, absolutely. Well, when you come to London, make sure you check out some of the Moore installations. There's one of my favorites is on Hampstead Heath in the north of London,
Oh,
sitting on a hill, and it's what I love is it's just there. You can go up to and you can touch something that iconic. Beautiful. So clearly a cultured lady. So let's go into the medicine. What inspired your transition from sort of common or garden hematology oncology to becoming a pioneer in palliative care? And what challenges did you face in establishing the first palliative care service at Dana-Farber and Brigham and Women's?
well, my patients are what brought me into palliative care. When I was doing hematology oncology, I was at the VA hospital that was associated with the University of Penn. And at a VA, when a young man gets something that is serious, like Hodgkin's disease or a germ cell tumor, they then go to the VA instead of active service hospitals. And I discovered this was in the era before any of the usual antiemetics. All we had was Decadron and Compazine and Ativan.
Yeah, I
And
remember that.
my patients were going to the Caribbean. Wasn't that an awful time?
Yeah,
And so my young men were going to the Caribbean and having enemas, and because what 19-year-old can tolerate platinum?
yeah.
So I became very aggressive in looking into, well, what has anybody figured out? And Gralla at that point had figured out that you could do metoclopramide 100 meters squared for 3 doses, along with a lot of Ativan and Benadryl. We didn't know that that dose actually hit the 5-HT3 receptors at the time. We didn't have Zofran. So I became fascinated about antiemetic therapy so I could save these kids' lives, which we did.
Yeah.
And similarly, I had patients with metastatic cancer back in the 80s. Their doctors were giving them Motrin for metastatic prostate cancer. And they came with their families to ask me to kill them. So clearly, I think of palliative care as life-saving. I studied at Sloan Kettering because they had the best pain group at the time. And I became what I would call an integrated palliative care primary oncologist hematology doctor for the 90s because of my patients. I needed to save their lives.
It's
The
brilliantly
challenges
said.
at Dana-Farber were what you
You
would
said.
expect. Oh, sorry.
I was just going to say that's
Thank you.
brilliantly said, and it's a lovely perspective that palliative care actually saves people's lives. It's an interesting perspective.
Well, that was my perspective. And I know that at the time, palliative care was more about communication. I was a Project on Death in America scholar, and my colleagues came into palliative care from the communication aspects. But I was an oncologist, and came into it from the suffering.
Yeah.
I couldn't bear the suffering. And so that was the angle I took when I got to Dana-Farber. Luckily, I knew a lot of the oncologists because we were colleagues. And I did work to show them I could take really good care of people. I was the inpatient attending doctor for their patients who had solid tumors, so I could show them that I'm a good doctor. Don't just put cool washcloths on people's foreheads. That's not what I do. And then went about working with the house staff to identify those patients who were suffering. And I said, could I do a teaching consult? I would ask the attending. I know you know how to do this, but I think for the house staff, it'd be good if I could do a teaching consult. So I went with the symptoms: intractable pain, nausea, delirium, the things that we know that cancer patients suffer from, especially when they're inpatients. They're sick enough to be an inpatient. And that was where I started my work. And I think that as you do the work and you take on the hardest cases, the oncologists saw what we could do. And more importantly, the nurses saw what we could do, and the house staff. And one of my proudest moments was when the ethics consultant told us, since you've been here for the last 2 years, we've had no ethics consults for intractable pain, because the nurses would call the ethics consultants for that.
Right.
So my fellow doctors at Dana-Farber were, I would say, no less advanced, probably more advanced in terms of adopting palliative care, because they didn't want their patients to suffer and they wanted them to get through their treatment. So they began to see us as allies in the outpatient and in the inpatient side of getting their patients through the treatment that could be life-saving or even curative. And of course, there are early adopters. The Berwick's curve applies to oncologists as well. And we
Right.
had some wonderful early adopters who even financially helped support us.
What about the adoption of cannabinoids to deal with nausea?
Hmm.
Because I know there was some, I won't mention any names, but one rather right wing, a religious individual basically said that he would never ever consider using cannabis, that this was evil. And from my perspective, to see someone with
Oh,
intractable vomiting or any kind of uncontrolled pain is heartbreaking. I mean, you just want to do something, and if that's cannabinoids, as far as I'm concerned, um, actually, there was a great comedian, Janet, I have to tell you, who did this routine, and he was saying that, complaining about people taking, older people taking cannabis, saying, I'm sorry, if someone's in pain as a doctor, bake them hash brownies, right? Let them mainline, do whatever it is, get rid of the pain. So, what your comment on cannabinoids?
Well, my comments, I should do full disclosure. I went to Berkeley in the 60s and early 70s. So in the US, that certainly. And I would say that people my age are very comfortable with cannabinoids, actually.
Yeah,
Luckily, in Massachusetts, they're legal.
yeah,
Unfortunately, federally, they're not.
yeah,
So our patients who are getting good relief from mostly nausea and vomiting and insomnia, as well as pain, can't bring their own medications into the hospital when they have to be admitted for something else. The idea that they're evil is ridiculous. There is an endocannabinoid receptor, the same place in your brain where there are other receptors for 5-HT3, for NK, all the chemoemetic preventive drugs we use take advantage of those receptors. We just haven't been able to do enough research on cannabinoids to free the high effect, which some people do not like, with the antiemetic and appetite effect. And
yeah,
now that finally, I believe the US has allowed research on cannabinoids and changed it from a Schedule 1 drug down to where you could do research, I have every confidence that there will be a very clean drug developed for that extra 25% of people who still are vomiting and have nausea despite olanzapine, despite all the other antiemetics.
yeah.
Because we have an unoccupied receptor. Why not occupy it?
Yeah, my friend Montel Williams has done a
Oh,
lot of advocacy work for cannabinoids for people with multiple sclerosis, and
oh, it's
I've known
very
him.
well described for that.
Yeah, and he was way ahead of the curve, and is and because he's a celebrity, he gets the ear time from the politicians. But I'm with you. I hope we can move ahead with that. So tell us, over the course of your career, how has the field of palliative and supportive oncology evolved, and what do you envision for the future?
Well, it's hard to believe I've been at Dana-Farber almost 25 years now. So I really have seen the field evolve. And I would say that it's becoming very mainstream when last year's ASCO president spent her entire presidential talk this June talking about the integration of palliative care and oncology. The challenge, of course, is there aren't enough of us, palliative care trained clinicians. We could see about 76,000 visits um, a day, and oncologists need 250,000 of us or so. I mean, there's so many more oncologists than there are palliative care doctors, and oncologists see 20 people a day. We can see maybe 10 people a day. So I think what needs to happen is there needs to be more primary palliative care, if you will, integrated into the oncology training programs, both graduate and undergraduate. I've developed this website this year for this very reason, because more than 60% of community oncologists have no palliative care partner. It's a completely free website. There's no a newsletter, there's no fees requested at all. And my goal was to be a partner with the community oncologists who don't have a palliative care partner. I think that there need to be more web-based resources, and but basic training, all oncology fellows should be able to do palliative care 101 symptom management and palliative care 101 breaking bad news and breaking really bad news, as I call it, when the treatments aren't working. We are lucky enough at Dana-Farber to be incorporated into the oncology fellow curriculum to do that communication training. And even with the residents at our hospital, the Brigham, we do communication training. But at the moment, medical schools don't incorporate these basic communication techniques or basic symptom management techniques. So it's a problem. However, the fact that Harvard is now having all of its first year students have at least a day of a palliative care experience with some hospice experience, that's a breakthrough. So I think that it's a matter of numbers at this point. When we're there, people use us. People love us. We've become a very, very well accepted specialty, I would say. We're
Yeah.
also really important for preventing burnout. If the oncologists really want to prevent burnout, they need us. They need us for their grief. They need us so that they are not having moral distress because of the suffering that they feel helpless to control. I think we're the answer for the 35 to 45%, which is scary to me, of oncologists expressing some form of moral distress or burnout. But I
I,
think
I
that we're on our way there. I really do.
I do wish that that's a message. I mean, I still meet people who tell me that their perception of our profession is that we are emotionally distanced from our patients. And I was explaining how I had sometimes sat with residents who were in tears because we'd lost a patient who needed time off because they were so distraught at someone who'd lost a limb,
Mhm.
or you had to do a mastectomy or do a major cancer operation, and they felt distressed because of what they had to do to save a life. And I just wish the general public understood it more. And I wish the people who paid for healthcare and the people who legislate healthcare understood what our profession deals with and does. So kudos to you. So Janet, you mentioned, your inspiration came from the patients you look after, and you mentioned some challenging cases. But what efforts do you believe are still needed to break the stigma, because there are still some stigma about dealing with this, that there's like a dividing line. Here you're being treated to extend or improve the quality of your life. Here, no, you're going to die, and we're just going to help you ease your transition. So how do we break that stigma, and how do we see that because we're all going to die, I'm reliably informed. How do we break that stigma and change the perspective?
Well, something the organizations are doing is changing the name to supportive oncology. As you know, there's a multinational association for supportive care in cancer. That's the way the Europeans have dealt with it, and they consider palliative care to be the end of life along with hospice care in some cases. We've changed the name of our department even to the Department of Supportive Oncology. Eduardo Barrera did a study showing that people will refer sooner if you're called supportive oncology. We need to continue to win the hearts and minds of the practicing oncologists. They need not to think that a grim reaper has joined their tumor board when we sit down. They need to see us as the help that we can be to enhance the lives of their patients and the curative treatments. We're doing efforts at Dana-Farber to partner palliative care, what we call supportive care teams, which include a social worker and a clinician skilled in symptom management in the different disease centers. Oncologists tend to work in teams as much as they can. So if you have specialty divisions, you need your palliative care, if possible, dedicated to several of those specialty divisions. If you're a community practice, though, the hospices should really reach out and offer their palliative care expertise to those community practices. Or if the practice is big enough, they could hire somebody on a part-time basis. I have many friends who were hired by cancer groups, several of them, to go and have rounds 2 days a week at their offices. I think what needs to be done is we need the opportunity to show our worth. Once we're there, once we have enough of us, uh, that will break the barrier down because they will see that we're there for life-sustaining care.
Yeah.
Um, Before I came to Dana-Farber, the previous head had been heard to say, "I will not hear the words palliative care mentioned in this institute," back in the 90s.
Wow.
But luckily, we got a new chief. And when we got there, we couldn't put notices up in the elevators because it was too depressing for the patients, quote unquote. So that was 2001, 2002. But all we had to do was really show how we can help their patients survive. And now we get many referrals on admission from the oncologist saying, "I'm admitting him for pain. Please see him today."
Yeah. Very much so. Yeah, you don't want a person suffering 1 minute longer than they have to, and also getting the message out into the community doctors, the family physicians. And
Yeah.
by the way, that website you mentioned, let's make sure that we put that
Yes.
up in the show notes so that people can access it and we can talk about it. So you've mentioned Europe, and you've been involved in international palliative care education projects. What differences do you see in the global approach to palliative care, and who does it well? What lessons can we learn from other countries? And frankly, just as an aside, this is one of my big bugbears. I practiced half my career in the United States, and there are some things about American medicine that are fantastic, top of the class, and there are some things that are bloody awful, and there are some things here that we do brilliantly, and there are some things here that are bloody awful. And I talk to British doctors and they turn their nose up at American medicine, and American doctors say, oh, we don't want socialized medicine. Well, stop it. We need to talk to each other. So international palliative supportive oncology, who does it well, and what can we learn from each other?
Well, I think many people do it well. I think it's a resource issue, as it is for many places around the world. I think that families are much more involved in the care of patients throughout the world than in the US. And hospitals make accommodation for and expect families to be doing a lot of the care of patients in Brazil, in Japan, in India, in other places I've been, that you don't exclude the family, you welcome and count on the family's help in caring for the patients. The barriers the families place can be about end of life care, in that there can be difficulties explaining when the resources are not really going to be helpful to the patient anymore. But I've noticed there's big palliative care associations in India, very sophisticated throughout the country, doing wonderful palliative oncology work. Tata, for example, in Mumbai, is well known. Manipal, Dr. Naveen Salins, who's been awarded multiple times, has started an amazing educational program in the university in Manipal, a town that looks a lot like Berkeley, actually. Um, and then Oncoclínicas has got a big palliative care effort in Brazil. They've put palliative care in, I don't know, up to 60 of their offices in northern Brazil just in a year or two. Sarah Aranda led that effort along with Clarissa Matthias. So I think you just need partners, you need champions. And when you have champions, they will make things work. Australia's obviously known for its palliative care. Because of the British tradition, they started hospice and palliative care way before anybody else in the modern era. I mean, they brought it back to us. So I think that uh, there's many systematic palliative care efforts in Canada, in all of the former British territories. But India particularly impresses me with the way they go about using the resources they have to take care of as many people as they can. It's
The,
been quite impressive.
the point you made about families getting involved, my time in America, I noticed how widespread families could be, 3,000 miles apart. And so you
Mhm.
don't have that supportive mechanism. Also, an absence of a social safety net. When my grandmother, many years ago, was diagnosed with she had a glioblastoma and
Mm.
multiforme, and it was untreatable. She was 90 something, still working by the way. She was working until a week
Whoa.
before she was hospitalized. She did interior
Oh
design
my
work. She
God.
was an amazing woman. But
Oh.
the family decision was for she wanted to die at home. But
Mhm.
like this, the social network jumped into action, and within a day, her home had been they'd put in grab rails and a disabled, but all the things that you can do to make life easier. I just think it's about having a debate. Years ago, Janet, I met a chap named Sherwin Newland who wrote a book called How
Oh,
We
yes.
Die.
Wonderful surgeon. Yeah,
He was an
wonderful surgeon.
amazing
Wonderful writer.
man, and we a very good writer. But it was about
Yeah.
having those conversations that people don't have because, quote, it's embarrassing. And of course, in oncology, in my lifetime, you didn't have a conversation in polite society about breast cancer. It was you
Mhm.
can't say that. But now we do, and the
Wow.
benefit is you've raised awareness, women have become empowered, and we need to
Mhm.
do that about end of life issues. And that brings me to a challenging question. Can you address the contentious issue of physician assisted suicide? There's a big debate about it on this side of the duck pond. And by the way, I lost my a young man who was the son of my dearest friends who ended his life. He was in his early 20s,
Oh,
and his mum told me that I cannot say the words committed suicide. That's not acceptable. You're supposed to
right.
say died by suicide. So what
Yeah.
talk about physician assisted
Committed
suicide.
sounds like a crime.
It
When
does,
you
yeah.
commit, it's the religious implication that you've
Yeah.
and a legal implication. You've committed a crime.
Yeah. Yeah. Well, it used to be, didn't it? It was
That's
an
what I'm saying,
offense.
and I
Yeah.
think it came from that. I don't think we've
Yeah.
lost the locution. I think we
Yeah.
should lose it. You're right.
Yeah.
We don't commit it. We engage in it, or we perform it, or we do
Mm.
something. In the US now, we call it medical aid in dying because it's more descriptive and maybe it gets that word suicide out of there. I'm not
Mm.
sure. Medical aid in dying, it suits the US very well, actually, because we're so all about ourselves, we're all about our autonomy. That's the difference also. Autonomy is such a huge value in the US. The rest of the world, it's much more about families. It's much more about how the community feels you should do things. But in the US, autonomy is key. And so medical assistance in dying has been utilized, the data suggests, by those people who want control of the time and manner of their death. It's not for intractable suffering. It's not for poverty. It's not for worrying about the costs that you're going to burden your family with. This has been very carefully studied for over 15 years since it started in Oregon. So the reasons people actually take the pills, I mean, only a third of the people who have the pills ever take them. So two-thirds are just comforted by the fact that if this becomes intolerable, I will have a way out. And my doctor has prescribed these things because patients don't expect us to abandon them at the most serious time of their life, which is their death. They really feel that we owe them the respect that we gave them when they had a treatable illness, to prescribe something that will take care of them in the way they want. So the debate has been that for some people it's life-saving because those two-thirds who don't ever take it might have taken their lives sooner if they didn't have that option. That's been written about in the New England Journal, that people took their lives sooner because they couldn't do this and they wanted it. I think the HIV epidemic was very important in the medical assisted dying field because partners would take care of their dying partner and then know that they were going to go that way. And that was just not okay. Same with the dementia, which is much more out in the open in the US now, too, that there's a certain place beyond which, if you're not you, you don't want to be alive. It has to have safeguards. It has to have humanity. And we sort of have a differential. Dr. Susan Block and Andy Billings, who unfortunately has passed, had a wonderful paper about what people are really asking for when they ask you for assisted dying. So there's a lot of stuff that as palliative care doctors we're consulted when people ask for that or stop taking their meds. And usually it's a matter of wanting to be heard. It's their way of saying, you are not listening to me. I am suffering. I'm afraid. I'm alone. I'm worried about my family. I can take this now, but I'm not taking the pain meds because I worry that there won't be anything left later. There's a very elegant differential for this. And so far, most of the people I've dealt with, I could help in another way. I don't take care of outpatients, and we're not allowed at the moment to do medical aid in dying in the hospital, in our hospital. I know in other countries you can, and certainly in the Netherlands and Switzerland, they actually do euthanasia. And in some ways, the disability community feels that it's really of danger to them to allow this. But then the oncology community feels that if you don't allow this, then you're condemning someone with a glioblastoma to who might not be as good shape as your grandmother was, but the kind of person who is not themselves for months and is suffering for months. Why is that okay? And the requirement to take it yourself. The ALS community is very mixed about this
Yeah.
because they have to choose if they want a feeding tube, and they have to choose if they want to be on a breathing machine. And if they want this, they have to choose it while they can still take it. You see?
I just think that and I went through this when I lost my mum, was to
Mm,
actually sit down and in detail write out my advance directive. Um, Now, I'd just
mm.
gone through a divorce, and at the time, my prior
Oh,
wife had my advance directive. But no, I mean, being serious,
yeah.
for goodness sake, spend an hour and write down what you will and will not find acceptable, because at some point it's going to happen, more
I think
likely
that
than
the
not.
exercise would be very good for doctors.
Yeah. And
I
it's good
think
for them, for
doctors,
their
before they
patients.
graduate,
Yeah.
should, no, for themselves,
Yeah.
should start to look at what would and would not be acceptable. Unfortunately, in the US, many places, that living will is not acceptable as a legal document. So what you need here is a healthcare proxy
Yes.
who is legal and who knows what your wishes are. And
Yeah.
if you are in an unconventional or non-standard, not unconventional would be the wrong word, if you're in a relationship that has not been sanctioned by law, then you need to be really careful who your healthcare proxy is.
Yeah.
Because again, during the HIV epidemic, parents weren't letting the partner see the dying person
Yeah.
because there
I
was
know.
no legal right for that partner to see the dying person. And that's not impossible now either, not just from HIV, but wherever. And sometimes you have to have the conversation with people to say, look, you don't want your parents to be the guardians of your son when you pass. What am I? I'm going to pass? What are you talking about? I said, look, you have a very serious leukemia and you could get hit by a bus for all I know. But all I know is you've told me that you want your partner to keep custody of your son. So we have to work on that now
Yeah.
so that that happens.
Yeah.
So sometimes it's that realization. And I agree. I think I got a lot of self-knowledge when I tried to read the Five Wishes form, it's called. That's a few too many choices, I think, in Five Wishes.
Yeah.
But I think for not first year, they do things in the first year that should be done in the fourth year of med school. Here we have 4 years of med school. And after you've done your clinical rotations is when you should sit down and ask yourself those questions, I think.
Yeah. So one other experience I had in the States, Janet, was I lived in California, and for California CME, continuing medical education,
Yeah,
I think it was every couple of years you had to do a thing on end of life care and pain relief, and I thought it was a brilliant idea. I'd love to see that standardized, frankly, just so that people, every doctor, could be up to date. Is that something that you're in favor of?
definitely. And I still have my California license, so I do those courses.
Yeah, yeah, they're very,
I
very
think
good.
it's very important because if there's no place in the standard medical or postgraduate curriculum, the state has an obligation to educate the doctors that are caring for its citizens
Yeah,
and
yeah,
to break through that barrier for them because it's not that they don't want to do it, nobody taught them how to do it.
yeah.
That's what I
So
try to share with my non-oncology palliative care colleagues is don't be angry at them, be compassionate. They are suffering because nobody told them that it was medicine's failure, not their failure. They feel they failed each patient who died.
And you've talked a lot about capturing the patient's voice and having a dialogue and being heard. And you've talked about the education of doctors. What about if a young medical student came to see you and said, "I'm not sure what residency I should do"? What you've got 30 seconds, Professor Abrahm. Sell your specialty.
Well, as you know, we never sell anything in palliative care. We explore. So I would explore with that medical student what they're hoping to get, what their worries are about their chosen field. And I would stress that the advance of palliative care as a specialty is that you are the agent. You are the person without any special tools, without any need to do anything invasive to a person. You are the one who can be the bridge between any specialty and the patient and family. You are the one who can address the suffering at any stage of serious illness of patients and families, and you work in a team so that you're not working alone. You'll have social workers, psychiatrists, nurse practitioners, physician assistants, pharmacists, a team to help you, chaplains too, of course, care for all the holistic needs of a human being. You don't have to be a reductionist. Med school will turn you into a reductionist if you let it. But you are a whole person, and if you want to meet people as whole people, then palliative care is a specialty for you.
Eloquently said. Why should I be surprised? Everything else you've said has been eloquent and precise. I'd like to finish by asking a question I ask everyone. If you found a magical genie, you're on Martha's Vineyard, you're on the beach, you kick a bottle, out pops a genie and says, "Professor Abrahm, you have 3 wishes." What would you wish for?
Well, we all know that these genies have 2 sides to them. So that the normal thing I would wish for, I worry about the downside, for everyone to be fed, for the world to have reasonable health. But I worry that maybe they'd feed them Soylent Green, and maybe I don't know what reasonable health would be to the world. So I worry, or we'd have Malthusian overpopulation. So I'm going to make it smaller. I'm going to say that I wish for good health for my family and loved ones. I wish for meaningful work. And I wish for more understanding of myself so I can bring a less encumbered self to my work.
You know, there's a quadrant that I like to use to reflect on myself, and on one of the axes is intelligence, insight. On the other is character. And the very worst of human beings are arrogant and ignorant, and the very best are wise and humble. Professor Janet Abrahm, you are very, very firmly in that quadrant. Utter delight talking to you. I hope I'm going to get to see you when you're in London, and that we can have further conversations, preferably over an adult beverage. I'd like to thank you for being with us today, and for everything you've done in your career thus far, and I'm sure we're going to continue to do. Thank you.
You're very welcome. Thank you for the opportunity to share. I appreciate it.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.